Good morning, good afternoon, and good evening. Welcome to the Best of ASCO Africa session, wherever you are. My name is Dr. Sitna Mwanzi from the Aga Khan University Hospital in Nairobi, and together with my colleagues Dr. Miriam Mutebi and Professor Julie Grallo, we are very happy to host the breast session this morning. We are going to look at 3 abstracts, and the abstract I'm looking at is the PARSIFAL study, which is the study that looked at the combination of cyclin-dependent kinase inhibitor Palbociclib in combination with either fulvestrant and letrozole or letrozole. I have no disclosures from this presentation, and just to note that the slides here are used with permission from ASCO. Cyclin-dependent kinase inhibitors in combination with aromatase inhibitors have emerged as important first-line therapies for hormone receptor positive HER2-negative metastatic breast cancer based on 3 critical trials looking at abemaciclib, ribociclib, and palbociclib in combination with different aromatase inhibitors, showing an improvement of median progression-free survival by more than 12 months over single-agent endocrine therapy. Just to note that there has been no head-to-head comparison before, looking to see whether any of these combinations are better than the other in terms of improvement in median PFS, and whether the choice of the backbone makes a difference in the PFS. The other reason to look at the study is the results from the Falcon study, where fulvestrant emerged to have a better median progression-free survival when compared to anastrozole as first-line treatment in the hormone receptor positive metastatic breast cancer. This study was done prior to the entry of cyclin-dependent kinase inhibitors, and hence the presentation of results by Dr. Antonio Cusack from Barcelona, Spain, presenting the PARSIFAL study, which is a randomized multi-center open-label phase 2 trial looking at palbociclib in combination with either fulvestrant or letrozole in patients with estrogen receptor positive HER2-negative metastatic breast cancer. The PARSIFAL study was a randomized study looking at patients who were ER/PR positive and HER2-negative with metastatic breast cancer who had not received any prior treatment for their advanced disease, who could be postmenopausal or premenopausal, and the premenopausal patients were required to have ovarian function suppression. And patients were defined to be endocrine sensitive if they had a relapse that was more than 12 months from the end of endocrine treatment or were endocrine naive. The study participants were stratified as to whether they had visceral involvement or not, or whether they had de novo or recurrent disease. There were 486 patients in this study who were randomized in a 1-to-1 fashion to either receive fulvestrant at 500 milligrams IM on day 1, 14, and 29, and monthly thereafter, and standard dose of palbociclib of 125 milligrams orally for 21 days every 28 days. On the second arm, we had letrozole at 2.5 milligram once daily continuously in combination with a similar dose of palbociclib. Patients were continued on treatment until they had progression or they had intolerable toxicity. The primary endpoint of this study was investigator-associated progression-free survival, with secondary endpoints of overall survival, tumor response toxicity, and an exploratory endpoint of biomarker sub-studies. The baseline characteristics were not much different in the 2 arms. The median age of 63 years. There was no difference in the performance status. Most of the patients were postmenopausal. About 60% of the patients had prior diagnosis of breast cancer, and about 51% of the patients had visceral disease, and again about 51 to 58% of patients having less than 3 organs involved, and majority of the patients had measurable disease. In terms of prior treatment, approximately 40% of the patients had received chemotherapy in the early breast cancer, whether it was neoadjuvant or adjuvant, and about 30% of patients received endocrine treatment. Majority of the patients received tamoxifen, followed by aromatase inhibitors, and we have about 14% of the patients who received both tamoxifen and aromatase inhibitors. In terms of the primary objective, there were 256 progression-free survival events and the median follow-up of 32 months. And in the final analysis, there was no difference in terms of median PFS when you looked at the letrozole arm or the fulvestrant arm with the letrozole arm having about a 3-month advantage. So the superiority of fulvestrant was not met in this study, but neither was a non-inferiority margin met because the confidence interval was less than 1.45. When you look at the stratification, in the non-visceral disease, there wasn't a big difference in terms of the median PFS, 35.9 months in the letrozole arm versus 36.6 months in the fulvestrant arm. However, you can see that in both arms, the median progression-free survival in those with visceral disease is much lower, and there is almost a 6-month difference when you compared letrozole and fulvestrant. However, this was not statistically significant. Whether a patient had recurrent or de novo disease did not have an impact, whether letrozole or fulvestrant was used in addition to palbociclib. The drug, there were no new safety signals in this trial with almost similar side effects in the two arms. A lot of this were contributed to by palbociclib in terms of neutropenia and fatigue, but there were no differences in the two arms. The conclusion from the authors was that PARSIFAL study did not show statistical superiority in PFS for fulvestrant plus palbociclib over letrozole, and the non-inferiority hypothesis was also refuted. There were no major efficacy differences observed with the two stratification factors, and with a median follow-up of 32 months, there was no difference in the overall survival. There were no new unexpected safety signals, and hence PARSIFAL study was inconclusive in establishing the superiority between the two endocrine backbone agents when combined with palbociclib. What does this mean for us in Africa? Although there was no African site included in this trial, there is no reason to suggest that there could be any differences in the outcome. We have been slow to embrace cyclin-dependent kinase inhibitors in combination with AIs in Africa, but this study, I think, solidifies the importance of this combination in the treatment of in the first-line treatment of hormone receptor-positive metastatic breast cancer in our setting. The median PFS of 32 months and an improvement of more than 1 year over single-agent endocrine treatment. But we need to note that a majority of our patients will be younger patients, and so we should not forget ovarian function suppression in our premenopausal patients. The backbone endocrine therapy in combination with palbociclib does not seem, at least in this study, to make any difference with similar efficacy with either fulvestrant or letrozole. Our choice will be based on the accessibility, the cost, and preference of the clinician of the patient. Letrozole is more readily available, is probably cheaper, and in the oral formulation may probably be the preferred choice for our patients. This treatment is well tolerated with good side effects, and this is something that we also see in our clinical practice. What we need to watch out for is for neutropenia, which leads to most of the dose adjustments. So thank you for listening to me, and I'm happy to take your questions in our Q&A sessions that's coming right up. I welcome you to attend our other sessions, and have a good day.